Hello and welcome to my channel. My name is Peter Abraham. I am a registered nurse, primarily in hospice, though I've worked in cardiology and long-term care. If you're new to this channel, welcome. Thank you for visiting and thank you for spending some time with me. This channel, we mainly talk about healthcare topics, chronic illnesses that often become terminal, hospice nursing topics, hospice caregiver topics, hospice family member topics, anticipatory grief, grieving. Um, the last several videos I was focusing around hospice documentation topics. I took a break to go over how I've created my book cover for the last book, Clinical Pathophysiology, a reference for hospice and palliative nurses, and the current book that I'm working on, which is Hospice Clinical Pharmacology. And I did finish at least the rough draft of that cover in canva.com. And then last episode, I went over the introduction. So before I go much further, because today's episode will be going over what's been going on with that from there, let me stop and take a moment to do what I encourage all of you to do, and that is what are you grateful for? I found in my life, and I never want to have a contest who had it worse in life. We've all had storms. If you're an adult, you've had storms in your life. But in my experience, that we recover from those storms, we're more resilient through those storms when we are positively minded, when we are grateful, when we look for the silver lining, when we look for that shining star in that complete and utter darkness, that glimmer of hope, we're more likely to bounce back than if we focus on the darkness that's all around us. So in areas of being grateful, yesterday was April 1st, not Fool's Day from that perspective, but that's when I get to tally up, what were the book sales for the month. And while it was less than February's 595 books sold, it was 543. I am grateful whether it's one book, 100 books, whatever the amount. So it was still a fantastic month in terms of being a small, uh, relatively unknown book author. So I'm grateful for that because that's God's provision for my wife and I. We're living on the revenues from the Amazon royalties. We're living on her Social Security, and she's working a part-time job. So all of that combined is allowing us to not have to dig into any of our investment accounts. We are semi-retired with a very uh, modest savings. It's That's its own long story for a different day. So I'm grateful for that. I'm grateful for continuing making progress in the books that I've been writing. I'm grateful for you who are coming here to watch my videos. At this point in time, this channel is not monetized. I'm not making money on this YouTube channel, and that's okay. I like helping people wherever I'm able to help. This morning, I was having a rather good conversation with one of my friends from that I met going to Harrisburg Area Community College. It's my nursing sweatshirt from there. Uh, Tyler, we met, I believe it was in a communication, might have even been an art class. I actually forget the name of the class, but Tyler is one of those um, wonderful people that I met. We kiddie around one another. He's younger than me, but I do believe what we have in common is that we're what we refer to as old souls. And when I say old souls, I'm not talking about our physical age, just the way that we look at life. We tend to be far more mature in our outlook of life than our age. When I was 12, I was told, you sound like you're someone in your 30s. And we're not talking IQ or emotional intelligence. We're literally just our spirit. And I'm not talking reincarnation. No, not going there. But we had a wonderful conversation, and I was going over Tyler's looking at potentially writing his first book, and I was sharing advice. Here's what you can do. I don't mind sharing this freely. So while this channel is mainly geared towards healthcare topics, if you're seeing, like I did post a video earlier of our gardening attempt here in central Kentucky. If you have questions and you think I might be able to help you, don't know, ask. Maybe I can. I'm not charging for my time. And I'm not saying that there might not come a time where somebody may ask something of me that would be a hefty investment of my time where I might say, hey, you know what? This is really consulting. Let's talk about it. But until then, ask. Anyway, don't want to go down too many rabbit trails. I'm grateful for Tyler. I'm grateful for opportunities to share with people. And even though this, oh my, the storms here in Kentucky lately, we were several hours without power, and but the energy company got the power on quickly, and I'm grateful for that. So moving forward with this book, I'm going to show you now. Chapter 1 is in draft format, and I'm going to be pausing after this chapter. So when we get to Friday, you're not going to be seeing chapter 2. Part of my time this morning was doing more of the outline, trying to reinforce like what additional case studies will I need, and making the upcoming chapter stronger, because you can go out there. There are dozens of clinical pharmacology books out there for nurses. I desire this book to be extremely tightly focused for hospice nurses only, not hospice and palliative care nurses. No offense to those who are strictly palliative care or doing both. But this is looking at pharmacology in the last 6 months of life, with the disclaimer that I understand that you will have cases like former President Jimmy Carter that was on hospice longer than a year. You'll have cases like my COPD patient George, who lasted close to 2 years in hospice for COPD. You're going to have those cases. But that aside, pharmacology, last 6 months of life, is very different than pharmacology for somebody who has years to live. So we're talking about kidney, your renal system, your liver, your hepatic system, and also the impact of cardiopulmonary, because when we have edema and we have the fluid in different places than it should be, that impacts the um, pronunciation. It impacts how medications are absorbed. It impacts bioavailability. So I want this book to be tightly focused. So the main goals of this book, and I stressed this in the previous episode, so I'm hopefully not killing a dead horse, so to speak, is as nurses, we deal with medications from two perspectives, two major categories. I'm not saying there are subs. So category number one, our patient is uncomfortable. We want to call the provider and make recommendations. Or we notice that the patient's having polypharmacy, and that's getting into emotional stress. They're taking too many meds. We've all been there. What do we recommend, and why are we recommending that? And what happens if we get provider pushback? And how can we deal with that? So that's path number one. And then there's path number two, which is we interact with the provider, or maybe we find out after the fact. I've had cases with home patients. They end up calling their own doctor and they get an order for XYZ. It's not that it's wrong, but what if there were certain things not considered, and you want to fine tune that? So this book I want to deal with that subject matter as well. So I'm going to jump into a screen overview of chapter 1. One of the things that you're going to notice in this book, in the previous episode, I was free trialing Scriniver, and actually adored Scriniver for the most part. The outlining, the ability to move sections within a chapter, chapters around, and knowing that it would handle my toughest case. My toughest case as a book author is I put everything into an ebook format. I already have the template. I'll copy a blank template, put it in a directory. I'll start writing. I'll start drafting. Everything gets done there. All of the alt text for the images, everything is done in that Word document. And then when I'm ready to get into paperback, I will copy and paste the meat of it into a separate paperback format that's been sized. I like the 6 by 9 format. So this is 6 by 9, and this is going to be one of the reference material for this upcoming book, as well as this, as well as this. Now, all of these books are 6 by 9. So when I copy and paste those into 6 by 9, that's great if it works out. But like when I did the clinical pathophysiology book and realized that that would be close to 500 pages, which I've done. This approaches 500 pages, but this doesn't have lots of tables. So it's easier to break apart the information for readability purposes. But when it came to the clinical pathophysiology book, I ended up going 8.5 by 11. This is not that book. This is clinical CBT applications. But I ran into a similar problem with when I went to put this in 6 by 9. It was like, wow, uh, the tables are going to cross too many pages. Uh, Paragraphs are going to be broken in too many areas, and I want easy readability, and I also want to be able to price this at good price points, especially with everything that's been going on with the economy. And Amazon determines the print cost. So print cost, they're cut, and then I get what's left over. So Scrivener was going to solve the problem of I need to have this in different formats, and I can just export it and tell it the format. It would handle everything easily. So at that part, it looked to be a joy. But with a lot of my books, there are some exceptions, like a lot of my dementia books. I don't use a lot of tabular data. This is for families and caregivers. This is for families and caregivers. So this is also 6 by 9. So I don't use tabular data for those, but a lot of my nursing books have tabular data. So this book has tabular data. I don't know if I could find a table. Okay, there we go. Has tabular data. And so what I was finding out in Scrivener is it doesn't handle tabular data well. It handles basic tables, and it doesn't allow me to format them visually appealing. So I'd have to export them to Word and then massage it. And it's like, if I'm doing that, why not use Word? So long story short, what you're going to be seeing for chapter 1 and any overviews moving forward is, until I find a product that has the features of Scrivener, and I did reach out to them, let me know, because everything else was wonderful. That was the straw that broke the camel's back, but it was only one straw, but an important one for me. So before I make this too long of a video, let me dive into showing you chapter 1, where I'm at, and going over some of the whys, and then I'll come back for a quick outro. Thank you. So this is a preview of, this is all unbelievably rough draft format for the upcoming book, Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. And this is going to be prognosis driven, so that's why it's tightly focused to hospice. Need to write the dedication. So this is just the ebook format for this book. We did an overview of the introduction last episode, so I'm just quickly scrolling down through that. But I mentioned tabular data when I was showing the overview discussion. But this is what I'm talking about. I do like that I can go in here and just go to table design and come up here and pick a particular design. Most of my books are not written in color, so I don't use the color coding there. Let me just get back to home. So that's what I meant for that particular case for tabular data. But let me go into what is chapter one, and that's looking at the core principles for pharmacology uh, related to hospice. So, like in many of my books, I like having learning objectives. It is my hope one day down the road for CEUs to be offered, continuing education credits to be offered either through courses that I create from the books or some way, some shape, or how. I'm not there at that point in time. But I do write these books in mind for that. And Ed Braddock, thank you so much, Ed, if you're watching this, mentioned that is his hope, as in mine too. This would be neat to be in nursing schools and as part of hospice orientation. That would be a wonderful blessing for me and for others. And yes, I'm biased. But part of what we need to consider is pharmacokinetics in organ failure. Edema does matter, ascites do matter. Throughout the books, I am going to have clinical examples um, of what matters. And in certain areas, we can do sub-Q. I know, I still remember when I worked for a Care Hospice when they were owned by Golden Living. So a Care Hospice is currently an Amedisys company, but they were previously owned by Golden Living. They're a York, well, I should say a Pennsylvania hospice company. York County, Lancaster County, Dauphin County, Adams County, and so on. I still remember in their comfort kits, if you were a cardiac patient, they would actually have IV Lasix available in the kit, even though I shouldn't say IV, sorry, IV push to be more specific, because we didn't do IVs. IV push, I mean, go back. I'm sorry. I apologize. I need more tea. I not IV push because we're not talking IVs. Intramuscular injection for the furosemide. Low albumin, that's liver impact. Go over the primary medications for impact for low albumin levels. What about when lab values aren't available? I mentioned in the previous episode, my foundation as a hospice nurse is rural hospice. I just mentioned the Care when they were owned by Golden Living. 100% of my patients then was rural throughout York County, unless I was on call. Then it was all 6 or 7 counties. When I worked for them twice. I took a break and worked at Kingston Court Manor Care during COVID. But the second time, that's where it was maybe 80 to 90% rural and 10% facility, 5 to 10% facility. But rural hospice, we rarely have labs. You might have admission labs, if they came from a hospital setting, but what if they, were at home and they were early in the hospital? So I am going to have as much as available as I did in clinical pathophysiology, that book. How do you recognize without lab work? Medications we need to be aware of. I am trying as hard as possible as I'm writing clinical examples, and there will be a chapter with case studies. Getting back to assessment tools, how do we deal with when you don't have lab values? Clinical examples again. Half-life really matters when you have a longer prognosis. short prognosis, and there will be a section chapter on short prognosis. If I have somebody, and this gets into palliative sedation, for example, I still remember Greg who lost his airway. Greg who had esophageal cancer lost his airway, and we did palliative sedation. And I still remember Dr. Eric Barr. Dr. Barr, if you ever watch my videos, I adore you as a doctor. Um, very, very hospice centric, patient centric. I cannot, doctors like Dr. Barr are beyond amazing. You know, I'd have to look up, I did save the notes for that actual case just because it's so, you never know when you're going to run into it again. But 20 milligrams of morphine, and I forget whether it's every 10 to 15 minutes, along with we had a haloperidol lactate loading dose, lorazepam intensol loading dose, and we're just giving as rapidly as possible, literally to sedate, not to kill, not to hasten death, but to make them as comfortable as possible. And at that point in time, being as blunt as possible, I don't care about kidney function. I don't care about any of this. I care about comfort, 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 comfort. They matter. The family matters. We want to get rid of the distress. And so we're going to operate fast, and we're going to operate under the doctor's orders for that. But if they have a greater than 6 week perspective, and some of you may be watching this and say, Peter, you're too tight on too liberal on the 6 weeks. It should be a greater than 2 week or a greater than 3 week. This, I'll let you deal with this. This is a non-judgmental channel. From my perspective, a lot of my families, I've had cases, I still remember, and I'd have to think on the patient's name, but senile degeneration of the brain patient, where they had pneumonia, and they were presenting as if they were around the 6 week mark, and the son wanted to try antibiotics, and we did. And we ran into some difficulties the first couple of days because this was an assisted living where the med techs would give up if the patient couldn't take their meds, which is fine. They'd start off with the regular meds, and they take a little bit and they start spitting. And then we started, just give the antibiotic crush. Give that first, see how they do, then go to the others. And if you can't, skip those. But she actually was able to start taking portions of the crushed antibiotic until it started kicking in, and she bounced back, still hospice appropriate. So we're not talking about somebody discharge failure to decline because we treated, but it worked. And so there are cases where we want to be more cognitive 6 weeks out. My opinion on the 6 weeks out. Again, somebody may argue you need to be more tightening that in. But again, clinical examples, practical approaches, starting slow, go slow, drug sensitivity. We really have to be careful of CNS involvements. I've had too many cases of, I love lorazepam intensol in many instances, but I've had so many cases of paradoxical reaction. That's where they have the opposite effect reaction, or it's working, but they're over sedated, and then you have too many parties. You're snowing them, and there's times where I agree, and times where it's like, arg. That's its own video. There are assessment tools for anticholinergic burdens. We do want to think of fall risk, especially for our facility patients where short staffing is still extremely present. Not saying that this doesn't matter in home settings, but home settings, I've had family members, and I do mean this literally, chain their loved ones into bed. And I'm not talking Frankenstein chains. I'm talking like seat belts that they got out of cars and that they wrapped in a way around the hospital beds. Um, and I don't want to get into that's abuse. Under certain circumstances, you could do it in a way. That's its own story. Again, clinical examples. Less than 6 weeks, symptom relief. Greater than 6 weeks, less than 6 months, we're doing a balancing act. Again, with the clinical examples. And as you're reading through, if you find anything like this is glaringly wrong, please comment below. And while this book is not going to be focused on deprescribing, while this book will be touching on deprescribing, along with taking every opportunity to deprescribe, it is not going to be a replacement, and just switch the camera around, for this book, Medication Reconciliation in Hospice Care. So we will go over in this book, or I should say the stop frail criteria. I've really, how to phrase this, I used to be a fan and still am of the stop start method for prescribing, that deprescribing that's used over in Europe. But after reading more on the stop fail criteria, and this does, I do give a comparison. Stop fail is more hospice centric than the stop start. The stop start over in Europe focuses on just your elderly or geriatric population, where stop fail is taking into account that limited life expectancy. Medication appropriate index. And what I've been enjoying as I've been writing my books, and I mentioned that is my hope one day to work with, whether it be online, Zoom, I'm not sure of the format, doing online courses or in-person courses. I would like to be able to offer continuing education credits through my work, but I'm currently been writing the books with that in mind. So every chapter does end with, here's discussion questions, here are practice scenarios, and here are Socratic questions. I use Nursing Central for my continuing education credits. This is not a promo of them, but I do enjoy that they're using Socratic questions versus having me do a test that I can take as often as I like to take until I get a passing score so I can get a certificate. Um, that's frustrating. You and I have, all of us have been there. So I really do enjoy putting these together, taking into account like a scenario for dealing with this end stage COPD, declining renal function. Again, this is looking at the observable signs versus lab work, rural hospice patient, 3 to 4 week prognosis, 8 out of 10 pain, 15 milligrams of morphine every 4 hours. What are you going to do? We know there's going to be renal impairment, but what are we going to do? Again, I'm going to focus on immediate comfort given that shorter prognosis. But this gets into that discussion questions, and if you were using this with a preceptor, to me that's where this really comes into hand. If you have the opportunity to go to the upcoming Alabama Palliative Care Association conference in towards the end of April, middle of April, depending on how you view time. I know that's its own discussion. How do you view time? Interesting question. Um, Shelley's going to be going over, and there's going to be an overview of my books. Um, but my books are being written so that once you read them and grasp everything, the goal is that you master the concept, that you only have to come back to the books occasionally, maybe not at all. I want you to be your own masters in the field. I want you to bloom. So that's it for chapter 1. Thank you so much for your time to watch going through or listen going through chapter 1. Uh, I don't know when the next video about this book will come out. I do want to work more on the outline for the following chapters, just to ensure that you, the reader, are going to be getting the maximum value for the money that you're investing in this book. If you saw anything in the chapter one or from last week with the intro, gee, that just doesn't sound right, Peter, I think you're wrong in that area. I don't know it all. Non-judgmental channel. Comment below. Let's collaborate and work together. And if you have any questions about hospice, I just had a wonderful phone call in between filming with a nurse by the first name of Vera, who is considering hospice for the very first time, and who had a wonderful discussion on, you know, is this what to think, what to do. And I'm not telling anyone what to think, but this is more about brainstorming as to realistic expectations. Here's what I would do in terms of interacting with human resources and setting proper boundaries with the hospice agency and not just the patient. A lot of times in nursing, and I'm coming to a close shortly, we're told boundaries, 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 but we are told from the perspective of us to the patient, us to the family, us to the caregiver, and we forget that we need to set proper boundaries with our employer as well. It's a mutual relationship for all of us. It is not one-sided. So thank you so much for watching. If you like what you're seeing, like, comment, subscribe. Thank you so much, and God bless.